Okay, so we've covered the basic sort of technology and physics of CT last week, and so now we'll look at some applications in cardiology. The applications in cardiology trail the development that has occurred in, I would say, both MR and obviously SPECT and echo, principally because CT, up until the last 5 years, struggled, to image the heart because of the need to acquire enough data to make high-resolution pictures. Basically, it took too long to do that, and it took too much dose. And so now we're at a situation where we can make these pictures like this in 150 milliseconds. And so you've got a volume in 150 milliseconds, and that became possible about 5 years ago, maybe 10 years ago in some places, but widely available for sale in the marketplace 5 years ago. And it will take 10 years for cardiology and medicine to catch up and start using it appropriately. They're way ahead in Europe in terms of their use of this technology in cardiology, and one of the reasons they're way ahead is because they did not adopt nuclear medicine, particularly SPECT, as rapidly as it was adopted in the United States. And so they weren't dependent on SPECT in Europe, and so there wasn't SPECT to displace, right? So it's just taking off in Europe, and they're essentially way ahead of us in terms of development of technology and everything here. And market forces keep pushing this down in the United States. So you can see the basic resolution now of CT, the nominal resolution, when you ask, well, how big is a voxel, as you've seen in the header or the images that you've looked at, is about 0.4 by 0.4 by about 0.6 millimeters, right, for the dimensions of a voxel. That's not the resolution, obviously, of the scanner. The resolution will be somewhat bigger than that. If we look at the point spread function and ask, what's the spatial width of that point spread function, it should be bigger than the smallest voxel you're willing to use to create a picture, right? And so the point spread functions are around a millimeter, somewhere in that range for these scanners. It's not a huge surprise. The spot size is about a millimeter on the X-ray tube. The separation of the detector elements in the detector array on the order of a millimeter, etc. And so the resolution is about a millimeter. You can imagine that something like a heart over 150 milliseconds is not going to stay stationary to within a half a millimeter over 150 milliseconds, right? It's a moving object, and so it's going to be, even if you go to a phase of the heart cycle where the heart is purportedly stationary or at rest, it will still be drifting around on the order of 1 millimeter in 150 milliseconds. And so essentially motion is the thing that's going to reduce your resolution to the greatest degree at this point. This is an image from a standard modern day Siemens scanner of someone who is absolutely normal. This is a 55-year-old person. And you can see that some of the features in this scan. So the aortic valve leaflets are very well resolved. They're less than a millimeter, right? But they'll be blurred out to about a millimeter here. There's a little chunk of calcium on this aortic valve leaflet that is observable with this technology that you wouldn't see with others. Again, the basic premise is that you have contrast agent in the blood pool, which is causing a greater attenuation of X-rays, and therefore the blood will show up brighter on CT, since the Hounsfield unit is linearly proportional to the linear attenuation coefficient. So we have myocardium, air, well, lung tissue here, which is mostly air, blood in the left ventricle, blood in the right ventricle. However, the contrast bolus has gone by. All right, so it was injected into the patient's decubitus vein in their arm. It went into their right heart first, and then to their lungs, and then back to the left heart. And so it's gone in this. So it's a bolus that's a few heartbeats wide, right? Because it's in the left ventricle, and it's coming. If we go this direction, it's coming out the aorta. This is the aorta. It travels down the coronary vessels. Here's a coronary. The right coronary artery is coming off here. This person has quite a small right RCA. And the left this is the left main coming off the left coronary cusp of the aorta here. Okay, and the blood in those coronary vessels, as you can see, is full of contrast, and so they have high contrast, which is why you can make this picture. All right, so when you go to segment out a tissue type and it's blood that has contrast in it, you can segment this out quite well from the underlying fat, the underlying myocardium. And then here's blood that's in the right ventricle that doesn't have a lot of dye in it, and so it doesn't show up terribly bright. The blood in the left ventricle does show up quite bright, but these vessels are separated away from the ventricular cavity. So clinicians, when they're reading these, if you just look at this picture and say, well, does this compare at all with a SPECT scan? No. Does it compare at all with an echo? No. I mean, it's just a total different fish, right? It's showing you different things. And so people have to learn how to read them. And interestingly, radiologists and cardiologists that read these, they do it in this plane. This is an axial plane, so it's in the scan plane of the scanner, right? And they just zoom up and down like this. They go down and they come back up, look at stuff, and then if they're looking for a vessel that's narrow, they just track it as they push through the stack of slices. And so they'll track that vessel as it goes down. There it breaks into two vessels. This is going to go this way as the LAD. This is going to go this way as the circumflex, right? You can see the circumflex cutting back around the left atrium. It'll go to the posterior wall of the heart. The LAD is going down that front groove of the heart. And the clinician is just watching that vessel as it descends and asking the question, does it ever disappear or does it get critically narrow, right? And they get really good at it. If you go to these conferences where people who do this for a living get together, they have these games at the conference, and it's like Jeopardy. You ask a Jeopardy question, but to get to the question, they have to get the call right on a clinical case. And so they put up the case, and it looks exactly like this. It's an axial plane. And the clinician has to page through the case. They go like this. They page through and look at all the vessels, and they have to make the call, right? And they say there's a critical stenosis in the RCA. And if they get that right, then they can answer the question for points. The people who are really good at this, they do that time and time again in about 3 seconds. They just go whoop, once through it, and they pick up all that stuff. So a human being can get super good at seeing that pattern of vessels go down and see one disappear or whatever, right? It's fascinating to watch. So many humans get really good at reading these things. And so here's that little white dot there is the circumflex artery that came around it, and now it's dropping down in the posterior wall of the heart, the back wall of the heart, and feeding all of this tissue back here, right? And you can see it go all the way down to the apex there. So that's how these are read. People very rarely use these diagnostically. Interestingly, they basically don't count on these for making a call. They look at these to determine whether or not the study itself has reasonable image quality, because you can see the entire field of view instantly, and you basically rotate around and go, oh, this is a good study. And then they go to the axials and make the diagnosis, right? If, on the other hand, when you did this 3D view, you turn around and the RCA just like breaks up into a noisy bit of mess, then you know there was motion, there was some other reason why we didn't get good pictures. We have to deal with that problem first, right? So that's usually what these are used for, and they're also used for marketing, you know, for just showing this technology is crazy good. So when you get down to it, so here's the left main. So we're going to zoom in on that patient we just looked at. Actually, let's go back and take a look. So we're cutting down the aorta. So here's the left main coming off, and then it breaks into two vessels there. So we're going to look at that break point right here. We're going to zoom in. And you can see I can either do it by going up and down, as clinicians do, or you can cut the 3D volume in a basically an angled plane to try and get all of the stuff that's interesting in one image, right? And you can even cut it in a curved plane, a plane that, well, it's not a plane anymore, a curved surface that cuts through the vessel and tracks it. They do look at those. So this is a plane that's been angled to image that vessel breaking into the two components, the circumflex and the left anterior descending. This is the left main. And so you look at it in this view, and then these lines here represent the cuts through the vessel that are shown over here. So these are the axial cuts through the vessel. So if I want to actually see the diameter of the vessel change as I'm driving along the vessel, I would look at these planes over here. And most of the time you can just move this interactively up and down and see if the vessel, you know, gets narrow or whatever. So here we can see a few features. Here the vessel's really wide open. It's really nice, like 4 millimeters or something, 4 or 5 millimeters. Big left main. This person's left dominant, by the way. It means that most of their heart circulation is the circ, and the left anterior descending, the right is smaller. So a lot of blood coming down there here. We cut this axially on this plane, and you can see here's the lumen. That's where the contrast is of the blood, and then there's this dot out here. All right, anyone know what that dot is? That's called coronary calcium. And it is the harbinger, it's the marker of where there has been injury to the vessel and then repair. So it's, if you have some kind of inflammatory injury to the inside of your vessel wall and it gets repaired by natural events, it usually leaves behind some chunks of calcium, right? And you develop these as you get older. So that's a chunk of calcium. So this probably is a soft plaque, you know, that's an active lesion surrounding this piece of calcium. And now this is where, if we were engineers that could make CT images with 10 times the resolution, it would be useful, because you're trying to image, is that this wispy thing here, is that lesion actually a bump on the outside of that vessel? I don't know. I mean, it's hard to say, right? You can look at where the calcium is and say, well, you know, it should be a bump. Sure looks like a bump. But if you could actually image in and around this lesion to get the composite parts of that active coronary lesion, then you're in a better situation to know how old is it, what's the appropriate therapy at this point, should we go in there and put a stent, or should we leave it alone, etc. So that's the calcium. And then, you know, distal to that, distal is away from the source. The vessel opens up to a sort of a natural LAD diameter, and here's a cross-section of that here. Right? If we push this plane back and we look where this is branching off, you can see it gets pretty darn small, right, compared to this. Right? So this left main descends down to this diameter when it's branching out into the left anterior descending. Okay, and then when it gets to the left anterior descending, which was our last slide here, when it gets here, it's actually quite big again. So that's probably not good, right? That basically, when you see things narrow down and then get bigger, it's not a good design. You actually want the thing just to monotonically narrow as you get further distantly away from the source. You don't really want it to go narrow, then big, then narrow, then big. That just causes problems, right? Like flow deficits. So this is a absolutely asymptomatic, very healthy, normal person, this image, right? This person can like cycle miles and miles and miles and swim miles and miles and miles. And then these were done at the NIH in normal volunteers for this new scanner, basically. And so a bunch of people were gathered up, and they're totally normal people, and just said, yeah, sure, I'll jump in the scanner, because this was this new Siemens 4 scanner about 5 years ago. And all this stuff comes out, right, that nobody knew was there. So you get basically a very nice three-dimensional volume, and you have to investigate that three-dimensional volume in some way. It's almost, in some ways, too much data, right? And this is the thing you guys are familiar with, those of you that are using either Horos or Osirix, where you can look at different planes simultaneously. It's called multiplanar reconstruction. And basically the yellow line here represents this image, as I cut down here, and the blue line here represents this image in the coronal plane. And when you're trying to figure out what's going on, you can manipulate these planes. That's good news and bad news. The good news is you can extract very detailed information. The bad news is you're now expected to extract really detailed information, and it becomes very costly. So you do one of these exams, and then a radiologist sits in front of this thing, and what are they supposed to do? Spend 20 minutes driving through it? That becomes like, you can't do that. That's just too expensive, right? The time, that person's time is way too expensive to have them driving through these data sets that much. So that it gives you another engineering problem, which is, we've got all this data, we're expected to find all this stuff from this data. How do you do that in an efficient way? Do you get robots to do it? Do you get lower paid personnel to drive through that data and create presentations such that the high paid physician who's going to make the call and sign off on the report, they're the person responsible for it, look at it and have absolute confidence that they're right in saying, yeah, this person should go to the cath lab, or no, this person's normal, right? So that's another issue, is that there's almost too much data, right? Because it takes so long to drive through all of this data with great detail. And there's just becoming more data. This is a new scanner that has been released by Canon, that used to be Toshiba. Toshiba, the company, got into some hot water, and they had to sell off some of their companies and one of them, a very valuable one, was the Toshiba medical imaging systems. So they put that up for sale. And cultural norms in Japan is like that. Toshiba Medical would never be owned by anybody else other than a Japanese company. So really only Japanese companies had the opportunity to buy it. And it was bought by Canon. And so now Canon owns Toshiba Medical, and all these scanners are now called Canon scanners. But anyway, that's all the business side. But this is a really cool scanner. This thing, they made the detector, so take a standard detector that would be in a Philips, GE, or Siemens scanner, and it's a 1000 by, say, 128 or 1000 by 256, and the elements are about 1 millimeter apart at their centers. These guys put their elements 0.5 millimeter apart, so in 2 dimensions. Right? So they doubled the number of detectors in theta, they doubled the number of detectors in Z. Right? So that's a huge change in spatial resolution, right? It's like a factor 4, and the question is, would you see any difference, in these pictures, or something else basically limiting our resolution? But this is that same patient, right? Imaged on this scanner, and you can see much higher resolution images in this thing. If we stop this, we can cut through here. So remember, that person's left main is right here, and that little lesion is right there. Let's stop there. Right, and now you're imaging that lesion with much greater detail, right, of where that piece of calcium is and what the dimensions of the vessel are. And looking at just the aortic valve leaflets, you can see much greater detail and everything. So the resolution does actually increase. So here is, that tiny piece of calcium imaged again on this scanner, and it looks to me like you've lost that whole sort of feeling like there's a bulge. It looks like this is a soft plaque that's growing into the vessel, and it has a sort of a flat space here. Here's the soft plaque, the coronary calcium, and the lumen here. This is a direct comparison of a lesion, a piece of calcium seen in the same patient's right coronary artery on the high-resolution scanner, which is on the left. This is the high-resolution scanner, and the state-of-the-art Siemens scanner, which is this somatome force scanner. And here's a comparison on the high-resolution scanner on the left and the Siemens scanner on the right. And so you can see the signal to noise here is higher, right? If we were just to measure the signal value, divide it by the root mean square deviation of the background, much, much higher over here. However, this image probably has greater information in it because it just has a higher spatial resolution, right? And here's another example in a different lesion where you're seeing this sensitivity to a very small piece of calcium giving you a very high Hounsfield unit locally versus what was seen on the Siemens scanner, right? So the spatial resolution is better, and it's useful, right? Because we're detecting things with greater sensitivity. And so I think this is where things are going, right? The next generation of CT scanners, probably each company will have a high-resolution version of the scanner. Right? Any questions about this? Is a very interesting, not just technical and physics question. It's like, can we make pictures of reasonable quality at that high resolution? Right? It's also an interesting business question. Do people want 1K by 1K or 2K by 2K CT pictures? I mean, now these pictures get huge. They were big enough, right? They were like one dynamic study is like 2 gigabytes. And now you put this in here, you're talking 8 gigabytes or more, right? 16 gigabytes per study if you do a dynamic study. And so, you're really pushing the bounds of what digitally you can do. So any questions about that? Yeah.
How long has the 1 millimeter resolution been the status quo?
That's a great question, and it's a pretty long time because the detectors in theta along that, they haven't changed their dimension in a long time. They've been around 1 millimeter for a long time. What has changed over time is the number of those detectors packed in the slice direction. And so once we got to 64 detectors in the slice direction, it was 1 millimeter by 1 millimeter in Z, and the fact that you had 64 completely changed the game of doing CT because you could do these scans in seconds, right, as opposed to minutes. And at that point, when each vendor brought out a 64 slice, 1 by 1 by 1 scanner, the sales just like took off and usage took off. In fact, the VCT 750, which is the first 64 slice scanner in GE medical systems, that was their best-selling medical systems product ever. right? It just flew off the shelves. They couldn't build them fast enough. But now, this kind of changes the whole calculus. Like, should we go to the expense? I mean, it's a big expense, right? You have a new detector, you have a lot more data processing and stuff like that. So, yeah.
In your experience, like how much more often would you change how you would treat a patient based off of the higher resolution image?
That's a fantastic question. So the question is, I just want to get on recording here, is like, so you have these prettier pictures or higher resolution pictures. How often do you believe it will actually change the management of the patient? And that's the critical issue. And a lot of studies are done to look at what, not only the change in classification of patient, which is one sort of endpoint, just say, if I have 3 classes of patients, definitely abnormal, in the middle, definitely normal, how often can I move people out of that middle box, right? So that's one thing. But then the next thing is, if they move out of the middle box, how does it change their life? Do they have to, take a new drug? Do they get therapy, etc.? So those are expensive studies, and you have to do it on thousands of people to sort of get the statistics right, and you have to do a normal control group, and so those are ongoing. And this technology, the high resolution technology, is new enough that those studies are just being thought up. And the big deal right now is, what's the best target initially to do a study such that ahead of time, if you're making this device, you think, yeah, it would make a difference in those patients. In cardiovascular imaging, it's a great question. I think the most probable thing right away would be earlier detection of calcium in young people. So rather than waiting till you're 55 to get your first calcium scan to see if I should go on a statin, you should do that at 45. And you'll see calcium when it's smaller on the high resolution system. And you'll know 10 years ahead of time, maybe I should go on a statin. Right? We'll talk about that a bit. But it's an open question for this. Talking about calcium, these are 3 patients who basically have exactly the same Framingham risk score. And so the Framingham risk score for whether or not you're going to have a heart attack in the next 10 years is based on about 6-7 parameters, which are your age, blood pressure, your LDL level in your blood. Framingham doesn't have family history, but whether you're a smoker and whether you're on blood pressure medication, things like that. So they're clinical parameters. You put this in a risk score and you determine, oh, you have about a 15% chance of having a heart attack in the next 10 years. That's high. And the statistics have been done on a group of tens of thousands of patients to determine whether or not those are the right parameters to measure. If you make a prediction based on the Framingham risk score as to whether or not a person will have an event in the next 10 years, and you test your precision of that prediction, your sensitivity and your specificity of that prediction. If you use the Framingham risk score alone, that's this blue, I mean, a lot of blue are here, but they're all about the same, and you draw an ROC curve. Remember we looked at an ROC curve back in image quality time? And we say, okay, if we want to pick up 60% of the heart attacks and predict and get a correct rate of 60% of the heart attacks, we're going to have accurately predicted those patients would have them, right? That also means we predicted 40% of people who didn't have heart attacks, we predicted they would have a heart attack, right? And so if you predict everybody's going to have a heart attack, you catch all the people that have heart attacks, but you also catch all the people that don't. And so that, is this point of the ROC curve. This is the 50-50 point, and then this is when you're working at low sensitivity. So the shape of this curve basically defines your sensitivity and specificity regardless of your threshold where you decide to call people positive. It's just the shape of the curve. This curve, right, all the way along, the sensitivity and the false positive fraction are equal, right? So that curve is flipping a coin. You certainly hope you're not down here, right? Because that's a bad place to be. You're predicting more people that don't have the disease than do. You can wind up down here, but that's a bad thing. And then all of these techniques have been essentially attempted to predict more accurately when people are going to have heart attacks. And we won't go through all these. These are basically measuring peripheral pressure in the ankles, doing, CRP analysis of the blood, all of that. All of those sensitivity specificity curves kind of lie on top of each other. Family history maybe goes up a little bit. This one, on the other hand, is coronary calcium. Okay, so if you do Framingham risk score plus coronary calcium in people who are in the middle pot of risks in Framingham risk score, this is how that curve changes, right? So it's really good. And it's pretty simple to understand why. 3 patients, they all have the same Framingham risk score, right? So they're probably about the same age, In this patient, when you image them with CT, you don't see any calcium in their coronary arteries. This patient, you see a small amount of calcium, and you quantify that. You just count up the amount of calcium, and you come up with a score. And then this patient, there is a ton of calcium, and it's all over, and so their score is quite high. That score, when you just use that as your threshold to determine whether or not the person's going to have a heart attack, predicts very well. People with high calcium scores, much higher risk of having a heart attack. Right? So, if you set your threshold to determine whether or not you're going to have a heart attack, say at any calcium, a calcium score of 10, if you see any of it, you're going to catch virtually 90% of the people that have heart attacks. You'll get them, but you'll also include a lot of normals. As you push the calcium score down and say, okay, if I put 250 as my calcium threshold, I'll still get 75% of the people, and I will include only 25% that don't have heart attacks. And so it becomes a fairly good predictive tool. And now this goes back to the question, okay, so what? You've done this calcium scan. What should you do? Is there anything you can do with this patient? Yes, there is. You can put them on a statin. Statins have been shown time and time again over many studies to reduce the frequency of heart attacks in patients that are at high risk. Right? And so taking a statin actually works. Right? And it's safe for me to say that on record now. There were physicians at Stanford who said it 15 years ago to their medical school class, and they were eviscerated. They were taken to task because the school said that they were supporting drug companies and all this stuff. The students went insane. They said, you can't say that in a medical school class. And so anyway, there's so much data now that I don't think students can yeah, go ahead. That's a great question. I had some people say, put it in the water, it should be like fluoride. And everybody take the drug. And, for certain people, that would be just fine because they don't have any side effects. And the only effect of the drug is that it seems their risk of coronary heart attack or coronary disease goes down. Other people, though, have side effects. And the side effects are like muscle pain. And then in some people, you actually get an enzymatic change to your liver, which causes a serious side effect. And so it's not without risk. However, to test it in an individual and see how they tolerate it, it's well worth that progress. So you don't really want to put it in the water, I guess. But it's clear that those people who are headed to this state when they're 65 and they're just growing lesions in their coronaries, they should be on statins as early as possible. Because it has also been shown that your risk of having a heart attack in the next 5 years isn't proportional to your LDL now. It's proportional to the integral of your LDL over the last N years, however old you are. It's the integral over your exposure, right? And so if you get that curve down and you hold it down, that integral doesn't increase as fast, right? And so that's also been shown recently to be true. So if you're a young person, you know, not 25, but if you're like 40 and you have a history of cardiovascular disease in your family, it's probably worth having a calcium scan because they're cheap and there's no contrast or anything like that. So this, and then if you saw this, you say, oh, okay, I should probably talk to a physician about going on a statin. Statins are off patent now, so they're cheap, right? So it costs about 15 cents a day or something, 25 cents a day. That wasn't the case 10 years ago. 10 years ago, it was pretty expensive. So if you look at, you know, it's all statistics basically. If you look at the Agatston score is this guy, I don't know what his first name is, Agatston. He came up with this calcium score on a napkin in a restaurant, right? So it's not a terribly well-engineered score, but it's sort of like a logarithmic transform of the amount of calcium that's detected on a scan. And then when you take the log of that score, actually, you get statistics that look like this, where the folks in red, this is the log of their calcium score. Basically, these are the folks in the 8,000 people represented in this histogram that had heart attacks, and these are the folks that did not. Right? And then this is their calcium score. So just because you have a high calcium score doesn't condemn you to having a heart attack, but you are in a group where the probability of having a heart attack, the ratio of the red to the green is much higher than it is down here, right? So here your probability of a heart attack is much higher. This, you know, is an interesting piece of data where if you look at a genetic risk score for having a heart attack, which has been done in these GWAS studies. So you take the 23andMe chip and you look at the SNPs in the people who have had heart attacks versus the people who haven't had heart attacks and see if any of those SNPs are up, you know, represented in the population of people who have heart attacks. And then you create a risk score from those SNPs, and there's about 100 of them. You essentially can create a genetic risk score for a person just based on their 23andMe data. And then that same risk score, I mean, it's been shown to predict heart attacks, but it actually what we recently showed is it also predicts whether or not you're going to see calcium on their CT. So if you have a high genetic risk and you're 40 years old, probably worth having a calcium scan, CT scan, right? Because you have a much higher probability of seeing a positive result. Okay, so statins are the way to go if you detect that signal on a CT scan. And really, the CT is the only way to detect that calcium signal. There's no other good, you know, imaging technique. You do it without contrast. You don't have to inject contrast, and so the patient lies in the scanner. It takes a fifth of a second to take the picture, and it costs about $100. So the other thing that has changed is the fact that because the rotation of the gantry is much higher now than it was before, you can take pictures over this 150 milliseconds. And so even if a patient has a very high heartbeat, right, so their heart's racing along at 90 beats per minute, even in those patients, you can still achieve these very high quality stationary vessels because you can choose a time in the R to R interval at which to obtain your data. And you could actually take pictures all across the R to R interval and look for pictures in which the motion is minimized, right? And so that's, if you take it all the way across the R to R interval, you take CT data and you just make pictures at different time epochs across that R to R interval. That's called fully retrospective imaging, and so you get the entire heartbeat. You can actually make a movie of the heart beating. But then you also have the opportunity to look for a time at which the coronary vessels are relatively motion-free. And the two highest probability moments for that to occur are at end systole, when the heart has contracted maximally and it's at its smallest volume. It pauses for a moment there before it opens back up. And so there is a moment at which it's relatively stationary. And then when it opens back up, after it's filled with blood, before the next beat, that's called diastasis. In that time, often there's a quiescent period, and that would be around 75% of the RDR interval. As the heart rate goes up, that position changes, but you can compensate for that. And the other fantastic thing is that because you're taking, if you know when you're going to shoot your image, and we'll say we're just going to take one picture and it's going to be at end systole, then we only need to have the x-rays on for a very short period of time, say 150 to 200 milliseconds, right? And at that point, you can make these pictures of coronary vessels, and you can use a remarkably low dose, i.e. very few photons get used to make this picture because it's taken over a short period of time. And so this actually won't mean that much to you, but recall that the radiation dose you receive just being alive and walking around is 3 millisieverts over a year. And then this picture for these coronaries here and this person took 0.28 millisieverts. So it's 1/10 of the radiation dose of the background. So you're now making pictures that are well below background radiation. And so you will never be able to do an experiment to determine if that causes cancer. You just can't. Because the signal would be so small, you'd need like 9 billion people to show a difference, right? So it's going to be way down. So that sort of alleviates the question as to whether or not doing this kind of study would significantly increase the radiation dose to a population. Remember, that was one of the issues when CT took off and people were getting a lot of CTs and ERs and stuff like that, was like, now the background radiation of the population seems to be increasing. The other benefit of being able to get everything done in a heartbeat, if it's done in one heartbeat, in a patient who has a very abnormal, or it's not that abnormal, but an unsteady EKG, so their R to R interval varies. And this isn't that uncommon. If all the data is taken in one heartbeat, you really don't care that each heartbeat's that different. You just need to trigger off a detected EKG from their leads that are on their chest, and then put your image at the right place and after that EKG, and you'll get a good picture. And so that's particularly in patients who are have poor left atria, like dilated left atria and atrial fibrillation. Those folks, their EKG is very, very variable. So it's hard to image them if you're trying to make images that assume each heartbeat is the same. And in most of magnetic resonance imaging, for example, you assume each heartbeat's the same. Recall in SPECT and PET, all of those assumed each heartbeat was the same. And echo 3D assumes each heartbeat's the same for about 6 beats. However, for that 2D echo, it was all real time, so you didn't really care. So the state of the art now, this would not have been true had we given this lecture like 5 years ago. But in the cath lab, when you evaluate whether or not a person has significant coronary artery disease, the state of the art is to measure the pressure across the lesion. Okay, so on the proximal side of the lesion, i.e. that side that goes out towards the aorta, you will have pressure in the vessel that will be closer to the systemic aortic pressure, which is up around the 120 millimeters mercury. If you go across the lesion, because the vessel narrows down, there is a pressure drop that occurs between the proximal side and the distal side of that lesion. And it turns out that pressure drop is basically a surrogate for how much flow attenuation there is across that lesion. So if you see a high pressure drop from the proximal side to the distal side, so it goes, the fractional drop is more than 20%, then that indicates that there is a significant flow reduction across that lesion. So the question now is, for the clinician that is in the cath lab and imaging a vessel and sees that their contrast dye fills the vessel, and then they see it get narrow, and then it fills the vessel again. So they see the kind of basically significance or the essential diameter reduction in that vessel. Should we put a stent in there to open that vessel up? Well, a large study was done in Europe in which they took these FFR measurements across a whole set of lesions and a whole set of patients. They randomized those patients to either receive optimal medical care or get a stent. Okay, you couldn't have done this in the United States, this study, because withholding a stent in somebody with a 90% lesion would have been thought to have been malpractice, right? So if you see a really tiny lesion on your angiogram and you say, no, we're not going to put a stent in that, we're just going to give you optimal medical care, that would not have flown past an IRB here. This was in France, right? So I guess they have a more open mind, right? Let's see what happens here. So they do this study. It was called FAME. I don't know, do we have it? Oh yeah, here it is here. It's called FAME 2. And it turned out, let's see if I have the results. Yeah, it turned out that if the drop in pressure was greater than 20%, the patients in that group, the patients who got the stent, did not come back to the hospital for emergent intervention at the rate that the patients who got the drug therapy did. So the conclusion is, you should put a stent in those people, right? Death was slightly higher in the drug group, but mostly what was higher was the fact they wound up back at the hospital with crushing chest pain and they needed therapy, right? They didn't die, they just wound up back at the hospital. So stent me now or stent me later. And so in this study, it said if you measure this FFR thing and it goes 20% down or more, put a stent in, right? But the fascinating thing about this study as well, right, was, and this is just a throwaway sentence, it's one of the throwaway sentences, but it's a sentence at the end of the manuscript that wasn't part of their, endpoints that they had anticipated. It said, among patients with stenosis that were not functionally significant. Functionally significant means they did not meet this 20% drop in pressure threshold, right? The best available medical therapy alone resulted in an excellent outcome, regardless of the angiographic appearance of the stenosis. So that means I can see an 80% reduction in diameter, a tiny thing like that. If I put this pressure catheter across there and I don't get a 20% drop in pressure, those patients didn't matter. If you put a stent in or you did drugs, they did exactly the same. Well, that is a huge deal. What that did was absolutely change medical practice in the United States, because up to that point, if you saw 70% stenosis or greater geometrically, just you measured it geometrically on your X-ray catheterization, you put a stent in. And if you didn't put a stent in, it was thought to be abnormal, right? That abnormal behavior on your part as a physician. Some physicians were very aggressive, and they said, anything above 50%, I'll stent, right? And you can imagine why, right? There is not only your desire to help this patient relieve ischemia, you get paid to put the darn stent in. This is one of the broken things about medicine in this country, is if I'm looking at it, and when I make the decision to put the stent in, I earn an extra $1,000, That's not a good thing. And that's exactly what it is here, right? If you do the procedure, you earn more money. So there are some physicians who are in jail. There's one in Baltimore. He was at Union Memorial Hospital. He was putting stents. And then, they looked at statistics, and they're like, this guy's 4 sigma up here in terms of number of stents he puts in per, of all of his cases. Perhaps we should review some of these cases. And they got a whole bunch of physicians to review the cases, and they're like, no, I wouldn't put stents in there. I wouldn't have put it in there. I wouldn't have put it in there. And so he's in jail, right? He earned a lot of money before he went to jail, but he's in jail. But that's the problem, right? This feedback loop of I get paid to do procedures is kind of, at odds with what you should do optimally sometimes. So this changed medical practice, right? And this was done using very good X-ray angiography, and we'll study X-ray angiography later, to determine quantitatively what the geometric stenosis was in those patients. So, like all biological data, this data is messy. So if you have the diameter stenosis here, so 100% diameter stenosis means that vessel is entirely closed off. It just comes to a stop. And no, you don't see contrast distally, okay? A 50% stenosis, you can imagine it's got a 4 millimeter diameter, goes down to 2 millimeters, and then goes back up to 4. That's a 50% stenosis. And then you ask, okay, in those types of vessels, for these different rates or geometric structure, what is the drop in pressure? A 20% drop means an FFR of 0.8. It's a normalized thing. No drop in pressure is 1. A 50% drop in pressure is down here. So you look at, say, well, 60% stenosis. So geometrically, that's in this group of patients here who had the 60% stenosis, right? You had everything from no drop in pressure to, a 40% drop in pressure for the same geometry, right? And so the question is this noise from the technology? Like, is this measurement of FFR that noisy, right? Or is it from the physiology? And from one patient to the next, you can just have a different measurement because that patient has adapted to this geometrical situation. I got a stenotic vessel. I need blood flow distally to that. How do I respond? I can get it from another vessel if I have basically this cross representation of blood flow from different vascular beds, right? So it's kind of a messy number. This was decided as the threshold, but you can see that, it's kind of, putting a threshold through this data and saying it's 0.8 as a precise number is kind of strange, right? Because the sort of natural distribution of the values is so high. And so here's your real mismatch data where you have these very high stenosis and very little pressure drop across them. And so that's where you have this situation. It has to be that these collateral vessels are feeding the territory that vessel used to feed, right? And so it just doesn't need, when you ask for more flow, it just doesn't need to give it. FFR here puts these patients in the box where you would say, yep, stent these things, open this thing up because they're having a critical pressure drop, right, across that lesion. And then, you have this sort of middling region here, right, where you've got a lot of noise. So there's still a lot of professional judgment, right, here. If you get this close to 0.8 and it's close to 50% as to what you're going to do, whether you're going to put a stent or not. I should note, just so that you don't think you just push this thing in and measure pressure, what you do is you push this catheter in and then you administer a drug, adenosine. Remember we looked at these stress agents? Adenosine dilates all of the distal vessel bed. And so they usually it's supposedly a systemic injection of adenosine, but a lot of times they just inject the adenosine straight into the coronaries. And then, so now you've dilated the distal bed and you look at how that pressure changes. And that's, remember this picture? So we're sitting here, you administer the adenosine and you get this change, right? Because the flow demand goes up. So that's the state of the art of, like, what is the gold standard at the end of the day for determining if this patient has significant coronary artery disease. This is it. It's FFR, and it's called fractional flow reserve, and it's done in the cath lab, and it's done with this catheter. And that is now the gold standard, right? Not quantitative angiography where you measure the geometry and decide if it's greater than 70% stenosis, that patient is significant. Yeah?
On average, how big is the catheter lead relative to like the diameter of the vessel?
That's a great question. So the question is, if the pressure catheter itself has a significant diameter with respect to the remaining diameter after that lesion has done its business in the vessel, doesn't that perturb the measurement as well? And sure, yeah, it does. And I don't know. I'll look up the new FFR catheters and what their French diameter is, and we'll take a look at that. But I don't know what it is. Right? It's got to be thin, right? Because you don't want to plug the vessel while you're Okay. I think if that's an issue, you're already in a kind of up in a zone where you probably should put a stent in that thing. But the interesting thing is, if you look at the Courage trial, and I recommend everybody read this thing, it's like 10 years old now, where they tried to show significant benefit from stenting coronary vessels that had critical stenosis geometrically. And what they looked at was survival. And that's a pretty simple binary outcome. Right? Did the patient die earlier than expected if you did not put a stent in? Or did they die earlier in the group in which you did not put stents in when you just did optimal drug therapy versus the group that got the stents? They did this huge trial, and it turned out it didn't seem to matter for survival, right? Which was a big bombshell at the time. And so the idea was that why do people get these stents then? It's if it's not for increased survival, right? Well, it's for decreasing their symptoms, because they come in and they complain of pain and they feel sick, and etc. And so that's what interventional cardiology put forward and said, no, but we're actually reducing critical symptoms. So a recent study looked at that, and they couldn't find a positive result for that either. So I don't know. It's an open question. However, if I had a critical stenosis, I'd stent the damn thing, right? I don't want a vessel that's shut down. I'd prefer to have one that's open. Anyway, determining when you stent a vessel based on the CT, obviously now, CT, even when you can see, so we've cut multiple planes now through the vessel at angles, so that we're running right along the vessel at a location where we have this stenosis. So you can see the vessel's probably 4 millimeters. It reduces down here to probably 2 millimeters, and then goes back up. Again, here comes down to maybe 2 millimeters, and then goes back up. So, we cut through the lesion on this blue plane here, and this is what it looks like in the axial view. Remember, it's 3D data, and so we look at the axial view. We say, well, how big is this? And let's put a measurement here, say at the full width at half max, and it's about 1 millimeter, in diameter, that vessel. So that's kind of a critical stenosis, right? It's 1 millimeter over 4. It's a 75% stenosis. So should you stent that thing? Well, we're in a position now where, even though we have these high-resolution pictures, we can't really make that statement based on geometry given FAME2, this trial. But what we can do, and this is really cool technology, some folks at Stanford who were doing very large computational fluid dynamics calculations mostly in large vessels, and mostly in folks who had congenital abnormalities to determine what the optimal surgical transposition of vessels would be. Well, they focused their attention on coronaries. I said, well, now that we've got the resolution, I mean, up until 5-6 years ago, you probably didn't have the resolution. Now that we have the resolution to actually create a mesh that is the coronary vasculature, we can run a calculation and determine what the pressure is along the vessel, right, given the flow that's going through that vessel. And if we measure the pressure as we move down the vessel, that's essentially like measuring the FFR, the fractional flow reserve, without a catheter in there, right? Just based on the computational fluid dynamics. This company is called HeartFlow, and I don't own shares in HeartFlow, although, you know, I admire these folks. I like these people. They've done a great job. And if you look at the drop in pressure and it's critical, then you can say, well, you should stent that stenosis, right? Just based on the CT. You don't have to do the angio. But perhaps even more importantly, it's those patients who don't achieve an FFR that shows a greater than a 20% drop. You can tell them, you don't even need to go to the cath lab, right? Just go on optimal medical therapy. You don't go to the cath lab and get invasive FFR done, because we know you're going to be well above the threshold for getting treatment. So we now have this available at UCSD, and so here's that stenosis we were looking at in the CT, and so it's coming. This is the left main here. The LAD is coming down here. There's the stenosis, and the drop in pressure shows that it would only be a 13% drop across that stenosis, and therefore you should leave that thing alone, right? And that patient went to the cath lab. They, you know, imaged them and saw this stenosis here, but they indeed measured the FFR and did not put a stent in. So the question is, should that patient have even gone to the cath lab? Probably not, right? Because, you know, when they look at it, they just would leave that thing alone, you know, and give them optimal drug therapy. Granted, you did discover that there's this kind of aneurysm down there, but that also can be seen on the CT. So that's HeartFlow in a nutshell, and it is a very new technology that has had FDA approval probably for about 3 years, something like that, and they recently got reimbursement approval from CMS, and in the United States, this is amazing. They have to go to every medical insurance company, not 3 of them, like 300 of them, and get those insurance companies, now that's been approved by the FDA and the CMS and all these people, to cover it. And so that's an army of people going and making these cases that you should cover this procedure, right? And one by one, these insurance companies are covering it. It is such a broken system. Okay, so this is a recommendation about using statins, and going back to our statin story, and I won't belabor this, but you can look it up. And it basically, if you have a relatively high risk of cardiovascular disease or a probability of an event greater than 10% in the next 10 years, you should be on a statin. That's what they state. Okay. The interesting thing is this it's called an ASCVD risk calculator, which is kind of like the Framingham risk score. This 10% is based on that, right? So you do that clinical thing. So now we have this technique, this non-invasive technique, to look at people's coronary vessels and ask, you know, how well does this ASCVD risk calculator, that is a non-imaging technique, how well does it stack up to predicting whether or not a person has cardiovascular disease at all? And so this is a really interesting paper. They 200 patients. This was in 2013, I guess. Yep. And so they took CTs in all of these patients, and they calculated their ASCVD risk for having a cardiovascular event. Okay, so now you've got the risk calculated for each person, and you kind of have the answer as to whether or not they are growing lesions in their coronary arteries, right? So 3 buckets of patients according to their CT. First bucket, the patient was clean, didn't have any lesions in their coronaries. This bucket, and there's 131 people in that bucket. In this bucket, there's 68 people out of the 200 had non-obstructive lesions. So that's anywhere from, say, 30% diameter stenosis to 85, 90% stenosis. And then, or to about 75. Obstructive CAD is 75% stenosis and above. Okay, so 20 people had actual obstructive lesions. The coloring here are, the green means the ASCVD calculator, would put you on a statin. It reached a risk to put you on a statin. So out of the 131, 30 people in this group were appropriate for statin therapy. And that was probably wholly based on their LDL drug level, which makes sense, right? That you should put those people on a statin. In this group, they're growing coronary lesions. Only half of them, using this calculator, qualified to go on a statin. Well, that's crazy. All of these people should be on a statin, right? So you're missing 50% of the people in this group. Even in this group, right? So these are people who've grown significant lesions, life-threatening lesions. 13 out of 20 using this calculator should be on a statin, and 7 of them they say you shouldn't be on a statin. So it's it's not a good way to determine who should be on a statin. The best way is look and see if there's a lesion there, and you can do that. All right. We won't do the PROMISE trial again because I did that as the example paper, right? But if you recall, 4,700 people, this group went to CTA first, this group went to SPECT first, 609 people sent to the cath lab, only 406 sent to the cath lab. Of the 609, 439 had disease on cath. Here, 193 had disease on cath. Huge difference in detecting disease burden between CT and SPECT. Not surprising, right? Granted, you had to treat twice as many people over here as you did here. So it's a more expensive life because you discover disease you have to treat, right? So that's not great for the insurance company. That's not great for Medicare. So the question now is, for an individual, if you've got these imaging techniques, and one of them, like CT, is a non-invasive imaging technique, super low risk, should you screen people to determine if they should go on a statin or whether or not they have significant disease? And should you screen people at all for heart disease? And it turns out the good folks at the Agency for Healthcare Research and Quality, the U.S. Preventative Service Task Force, they're part of Health and Human Services. They look at all the literature to determine whether or not a process or a procedure is actually optimal. And they say basically you should not screen for heart disease at all using any technique. You shouldn't screen with ECG, you shouldn't screen with stress tests, you shouldn't screen with SPECT, whatever, because essentially you will uncover a lot of disease and you'll treat too many people. Is kind of their, in a nutshell. It's a long report. But the downstream effect would be too many people get treated. And then without any irony, without anything, this statement at the end of the report comes out, which is reasons to consider screening an individual patient, right? So a specific person, not a population. Select occupations such as pilots, where sudden incapacitation or sudden death may endanger the safety of others. What the hell does that mean? Why screen the pilot? versus us. A pilot's more valuable than us. That's what that states. For us, we do not reach the value level to screen, even though they know if they screen these pilots, they're going to uncover stuff that they should take care of. But my point is, as an individual, so that's from a government standpoint. Do I screen my population? Right? Well, I'll screen the important people, the C-level executives and the pilots, right? I don't have to screen the population because it's gonna push me into a huge treatment regime, right? When you do the calculus from yourself, from your own standpoint, right? Should you screen yourself? Well, hell yeah, right? You want to know, am I growing lesions and should I be on a statin? The calculus, your value calculus, is not the whole population. Your value calculus is my family and me. You know, does this pay off? Of course it does. It's a binary thing, right? It's not a shift in life expectancy per dollar of a population. For your own calculus, it's like a binary issue. Should I or should I not go down this pathway? And so it's fascinating, you know, that they put it this way, and basically this is an economic decision. It says we are not of value to do this as a group, you know, from your insurance company, or as a group from Medicare, or as a population. It's really interesting. So one of the things that CT, high resolution CT, when the vessel actually is motion free, or you can do motion correction, and you have a scanner that has high enough resolution, you can start to see individual properties of lesions, not just their geometry, i.e. a 75% stenosis versus a 50% stenosis. You can actually look at the lesion and determine different characteristics. And this is called, you know, plaque imaging, where you're looking at the individual lesion itself and deciding what kind of lesion it is. And here we have purely, you know, detected soft plaque that has a bump on the outside of the vessel. So the geometry of this lesion is called positive remodeling, or PR. It bumps on the outside, and it's like a fibrous tissue or lipid-filled core here, which grows on the outside. No calcium in there, so it's a completely soft plaque. You wouldn't see it on a calcium scan. These are not good. They're young and they're dangerous, these lesions. Here's one where you have soft plaque. We saw this in our volunteer before, and a little bit of calcium in the middle, right? But you can actually visualize the fact that there's soft plaque outside here. And here, this is usually what you see in a person who's like 70, where they've had these over and over again, and they've resolved, and it's left behind this trail of plaque, which is heavily calcified vessels. It's almost like building your own stent. Like this huge calcified vessel by the time you're 80. And looking at all these different plaque patterns, one of the things that will emerge in the next decade of being able to image these things is which patterns predict that you're more likely to have acute coronary stenosis or an acute event. Wind up in the hospital with massive chest pain. And those people are the ones that you actually want to try and give heavy statins to, or even preemptively stent, although that is something that's probably not going to happen. You can see also a very different structure of calcium in some vessels, where you get a nice linear plaque here versus all of this, you know, particulate calcium that's obviously different lesions being repaired. So that's, you know, in the future, when we get to higher resolution CT and we get to very good motion artifact correction, we'll be able to make these phenotypical images of individual plaques. That's where it's going. Okay, I'm going to stop there, and Thursday we'll do CT applications, and in the last 20 minutes we'll do the presentation. Okay, at the end of the class. All right. Any other questions about today's topics? All right. We'll see you on Thursday.